Hello, everyone. This is Brittany Davault for our presentation on diversity. This is for SPCE 682, Section 803, taught by Dr. Mary Warp. To start off, what we're looking to accomplish today is to define and elaborate on cultural competence. Then we will focus on three key demographics that are applicable to our area, which are Hispanic culture with ASD, African American culture with ASD, and low socioeconomic status and rural residents. The purpose of focusing on these demographics is to bring awareness to the differences these families may face from what we have experienced and bring more empathy into our service deliveries so that we may better care for our families. So, culture, what does that exactly mean? Culture is a set of behaviors that have been maintained through social interactions within a group of people. Examples of this would be the food you eat in your family, attending church, how you say hello, the clothes you wear, the music you listen to. The list can go on and on. So, we've got a lot of terms to kind of mean the same thing here. We see it all together. So, is it competence? Is it sensitivity? Is it awareness? It seems these terms are used interchangeably. It's all in the connotation with the words. In practice, they're all really meant to convey the same message, which is understanding your own values and beliefs and recognizing that of others. This applies to both public and private events. Ignorance. It's part of being human. We will never know everything about the world we live in. However, as practitioners, we are called upon to educate ourselves and stay curious. When we think about not knowing everything, we veer towards the adage of we don't know what we do not know. This is partially true. However, an awareness of a lack of knowledge as a practitioner is crucial to jumpstart your curiosity. When encountering new cultures, that should be a flag to you to start asking open ended questions or researching reputable sources of information surrounding this new culture and approaching the professional relationship with empathy, compassion, and genuine curiosity so that you may best serve your clients. As a special note, this is not a start to finish process, it's an ever evolving process with no end. So, implicit bias. Implicit bias is a concept inextricably linked to promoting diversity, as it is a covert form of discrimination that one is not aware of. Privately held beliefs could lead to micro forms of discriminatory behavior. As clinicians, we need to be aware, that seems to be the word of the day for us, aware that we may hold stereotypes that cause us to treat others differently, which goes against our code of ethics. One method for establishing whether or not this is occurring with you is an IAT, an implicit association test. It's a free online test that shows you pictures of culturally diverse people and words that have positive and negative connotations. A newer method is an IRAP, the implicit relational assessment procedure, which is another computer-based test to look at relationships between ideas and peoples versus associations. Research is sparse for interventions for decreasing implicit bias, but Yaramio and Noelty suggest that we utilize applied behavioral analysis to assist us with this. Some suggestions from their article include self-management, behavior skills training, and reinforcement. So what are our obligations as practitioners? Sections of the BACB's ethics codes that cite diversity inclusion are as follows. Under the umbrella of responsibility as a professional, we have 1.07 cultural responsiveness and diversity. This calls on us to expand our knowledge of various cultures. 1.10 is an awareness of personal biases and challenges. This calls on us to keep ourselves curious and informed of our own thoughts and actions and how they affect service delivery and take action to resolve any issues. Under the umbrella of responsibility and practice, 2.13, selecting, designing, and implementing assessments. This calls on us to seek out assessments that best fit the diverse needs of our clients. On top of that, we have 2.14, selecting, designing, and implementing behavior change interventions. Same here, but selecting interventions that best meet the needs of our clients. And under the umbrella of responsibility to supervisees and trainees, 4.07, we are incorporating and addressing diversity. This task is meant to ensure that those in training are receiving education on the topic of diversity. We're going to move on to our key demographics mentioned earlier. First, we're going to start off with Latino and immigrant culture surrounding ASD. Mexican heritage individuals are at greater risk for more severe ASD symptoms than their white counterparts. Research shows that this group underutilizes mental health services. Some Latino families may see their ASD child as a punishment, a gift, or a test from God, which could influence how how and when they would seek treatment options. Some Mexican heritage families may see illness as biological or spiritual, in which they would seek out a doctor for biological, but for a spiritual illness, they would seek the services of a healer. So, if a family believes that their child's ASD symptoms are occurring due to a spiritual ailment, they would probably not be seeking the guidance of a doctor, which would greatly reduce their chances of coming into contact with diagnostic and ongoing services. Also, an ever prevalent theory is still circulating that vaccines cause ASD, which is still the case in this culture. So, some barriers for our Latino families. Obviously, the go to thought is the language barrier. If a family only speaks Spanish, then interpretive services obviously need to be in place to have appropriate conversations with the family. Next one we want to be mindful of would be the surrounding beliefs around child rearing in general for Mexican heritage parenting. These themes usually focus on social politeness and proper behavior. As we know, ASD can have accompanying behaviors that don't align with those values. When children have large emotional reactions in public spaces, this causes the mother to feel distressed and labeled as a quote unquote bad parent, which no one wants to feel that way. This could feed into how and or when diagnostic and ongoing services would be sought out, the parental level of stress, and the social family network. So what should we be doing? First off, we're going to be armed with research. Knowing that the vaccine theory is still looming around, you should have current research refuting that. Um, Next, if a language barrier does exist, we ideally would have an interpreter in person or on the phone. Those resources aren't always an option for everyone, so even using a phone-based app that does real-time translation would be better than nothing. Lastly, be equipped with understanding their position. Coming from a culture that blames parents for children not acting appropriately would put an enormous amount of stress on anyone. This could lead to isolation and feelings of depression, so approach with a high degree of empathy. Also, remember to work with and not against your families. Meet them where they are and work with them to get where they want and need to go, which means incorporating family suggestions and ideas into service delivery. So, for next key demographic, African American culture. A study done by Burkett et al. In 2015 looked into 24 family members that were African American and their approach to their child with autism. These families generally cited a of the clinical and healthcare, distrust of clinical healthcare, an obvious hindrance to an early diagnosis and subsequent access to earlier services for their child. There was a consistent theme of fear for their child as well in novel situations wherein they could be in danger, like approaching strangers or engaging in elopement behavior. Overarching themes were protecting their child and treating them as, quote, normal. The hope with this approach is that it will boost their child's independence. The study interviewed participants about their beliefs surrounding ASD and found that there was a lack of knowledge surrounding ASD, which has thus fed into a stigma around it. As of now, the difference in diagnostic timing is 1.6 years later than in white children. African American children are also more likely to be misdiagnosed with adjustment disorder or a conduct disorder than in Caucasian children. Research has shown that discrepancies in diagnostics could be due to the behavior of the healthcare provider using stereotypes to guide their interactions and diagnoses. Even with accounting for socioeconomic status, research has shown that there is decreased access to adequate healthcare for African American children. Mothers in the African American community are also not trustworthy of medical providers and are more hesitant to see providers for fear of discrimination. So, what should we be doing for these families? We should actively listen to our families and focus on not only their strengths, but also areas of concern. The family knows their child best and what they need. We should be working with, not against our families. Yes, we have behavioral sciences knowledge, but we do not have the knowledge of all their family dynamics and what would work best for them in their lives. Using suggestions from the family to augment service delivery is key. Do not dismiss ideas they have because they didn't come from you and you alone. They know their lives and how it works best. Always seek to empower the family and their ability to care for their child. So now on to our last key demographic, socioeconomic status and geography. Lower SES is actually correlated with decreased availability of diagnostic services and diminished access to services as opposed to symptom severity. It's also correlated with later diagnosing, decreased use of services, and lower satisfaction rates. In lower SES families, transportation may be difficult to obtain, which would make getting their child where they physically receive services inconsistent or unobtainable. The cost for services is also astronomical, so paying out of pocket may not be an option, hence an inability to receive services. We also see what I will refer to as a care desert. This would be an area that has little access to behavioral services. Sure, there are many towns and areas that are abundant with options, but when we get into more rural areas, these options begin to dwindle like where we are. With less availability comes less options, or a take what you can get attitude. And if what a family has access to is not good quality, and they do not have the means to change, dissatisfaction will remain. Lower SES families report that a lack of knowledge is a primary barrier. They just don't know what options are available and how to access them. They are also more commonly requesting respite care and in-home parent training, which feeds into the lack of knowledge. So, for this demographic, what should or can we do? First, we need to find out what their journey with accessing services has been so far and get a baseline knowledge for that. Next, we meet them where they are, whether that is educating them on free social groups to attend, how to obtain a diagnosis, or how to obtain grants or funding to allow their child to access services. This can also be an opportunity to educate them on ancillary therapies such as speech, OT, or any other relevant sources for the future. Next, we get that family all of the relevant materials they need: phone numbers, addresses, grant waivers, applications, educational pamphlets, respite applications. The list goes on and on. And then we listen to what they have to say and work collaboratively on how best to get them on the right track to securing and receiving the services they need. Here are my references for today's presentation. Thank you all for attending. I hope this brought to light barriers for us to understand that may assist us in providing more robust services and increase our awareness of other cultures. Have a nice evening.